then that extra acetylcholine you just added only exacerbated their acetylcholine overload. They're in cholinergic crisis, and you need to discontinue their cholinesterase inhibitors. So this adjacent phone booth here represents cholinergic overload, as depicted by the extensive anti-esterase and stigmine graffiti. The phone line's cut, so it looks like the edrophonium phone is not going to work here. So when you see these two phone booths next to each other, think of the tensilon test, which again is the marketing name for edrophonium, which can distinguish between overactivation by acetylcholine leading to paralysis by cholinergic storm, or by lack of acetylcholine, as in the case of myasthenia gravis. Aside from treating myasthenia, cholinesterase inhibitors can also reverse neuromuscular blockade. Neuromuscular blocking agents are used during anesthesia to produce muscle paralysis by interfering with the motor end plate. So there are two types. The non-depolarizing agents, such as rocuronium, vecuronium, and pancuronium, competitively inhibit the nicotinic receptors at the neuromuscular junctions, and these curare-like compounds act like curare crayons, blocking up the end plate, preventing transmission. It looks like some prepubescent punk is trying to make things difficult for our cleanup crew. Well, after surgery, it's usually desirable to reverse the pharmacologic paralysis. This can theoretically be accomplished with cholinesterases such as neostigmine, as we're portraying here with our neon sign store owner who's kicking out this curare kid. So that was one type. Remember how I said there are two types of neuromuscular blocking agents? There's only one depolarizing neuromuscular blocker you really need to know. See this other motor end plate outlet covered with graffiti spelling out the word sucks? What really sucks is that we have one of our cleanup crew members getting a depolarizing shock while trying to clean the graffiti that covers the end plate. This depicts the action of succinylcholine, an agent that causes a depolarizing neuromuscular blockade. Succinylcholine is basically an analog of acetylcholine, and it doesn't get metabolized as well, so it just sits there, overstimulating and depolarizing your NMJ, causing your muscles to remain depolarized and unresponsive to subsequent impulses. This initial overactivation or depolarization step is called the phase 1 block of a depolarizing blockade, and as our phase 1 cleanup crew member has unfortunately discovered, using cholinesterase inhibitors at this stage will only send further acetylcholine into the synapse and potentiate this depolarizing blockade. Of note, phase 2 of a depolarizing blockade is a little more complex, and cholinesterase inhibitors may actually be useful in reversing the block at this point. Okay, with all this extra acetylcholine thrown around, remember that cholinesterase inhibitors activate muscarinic receptors as well. This causes the parasympathetic effects, such as pupillary constriction and bowel and bladder activation. In fact, neostigmine can be used to treat postoperative urinary retention and bladder distension, as depicted by this bladder-evoking hose, similar to the one employed by bethanechol Beth. So let's move across the street where we'll cover our last anticholinesterase agent, physostigmine. The actions of physostigmine will be depicted inside this phys ed center. It's a little run down, but it seems like a nice, safe place where kids can escape the stress of city life and, you gotta be kidding me, graffiti here too? Well, actually that's pretty impressive artwork. I'd be pretty proud if my delinquent son channeled his creativity into such expressive vandalism. So why Alice in Wonderland? Well, on your exams, remember that physostigmine can be used to treat atropine overdose. As you'll see in our next sketch, the muscarinic antagonist atropine can cause all sorts of wacky symptoms, making you as mad as a hatter, hot as a hare, blind as a bat, just like all those characters at Alice's tea party. Atropine Alice here is also accompanied by the belladonna flower, to remind you that atropine-related compounds are found in nature, such as in the Atropa belladonna flower, or deadly nightshade. This means that an exam question may involve a man previously working in the garden, moments later presenting to the ER with those classic antimuscarinic symptoms of atropine overdose. So belladonna alkaloids are also found in Jimson weed, hence the weeds here and the word Jim written over the entrance. Jimson weed poisoning is also called gardener's mydriasis and is strikingly similar to atropine overdose. The muscarinic blockade caused by atropine overdose is competitive in nature, and it can be overcome by increasing the amount of endogenous acetylcholine at the synapse. Physostigmine, therefore, reverses these effects, just like this phys ed teacher here reverses this little atropine punk's poor life decisions. Unlike other cholinesterase inhibitors, physostigmine can enter the central nervous system, as depicted by this brain on the classic public service announcement straight out of the 80s. This is your brain on drugs. This means that it can reverse the peripheral and central effects of the atropine muscarinic blockade. However, physostigmine itself can also produce dangerous CNS side effects as well, so it's pretty sparingly used. The toxic effects of cholinesterase inhibitors are similar to those of the direct-acting muscarinic agents. Think of all those parasympathetic effects from the Paracity sketch. In other words, diarrhea, urination, meiosis, bronchospasm, bradycardia, lacrimation, salivation. Patients will also be sweating because sweat glands are activated by muscarinic receptors. So the mnemonic here that you can remember is dumbbells. It's used to remember all of these moist and sticky muscarinic effects. And we've depicted some of them here with this sweaty, somewhat poopy kid struggling with these dumbbells. So the dumbbells mnemonic is written here to help you remember them. You can pause them and write them down. Notice that we've also made them too weak to lift them. And this brings up a really important point. Unlike the direct-acting muscarinic agonists, cholinesterase inhibitors also cause that nicotinic receptor activation, as depicted by his nicotine-ridden cigarette. At the NMJ, nicotinic receptors are overactivated, leading to a flaccid paralysis, similar to that of depolarizing blockade that we discussed earlier. Ugh, man, you guys smell that? No wonder that kid's about to collapse. The major cause of acute cholinergic toxicity is organophosphate poisoning. Organophosphates are cholinesterase inhibitors themselves, found in many pesticides used in agriculture and in the household. The word thiol, printed on the insecticide canister, should remind you of the thiosulfate insecticides that often pop up on exams, such as parathion, malathion, and ecothiopate. These agents can cause slowly or rapidly developing muscarinic and nicotinic symptoms, which can persist for days and even be fatal. Remember that brain poster as well, because CNS involvement usually follows rapidly, causing cognitive deficits and convulsions. The classic scenario involves a man brought into the ER by a coworker because he was unable to continue picking vegetables or some other farming or gardening activity, and your patient is bradycardic, he's tearing excessively, remember those runny symptoms, and he can't breathe. So what to do? Acute organophosphate toxicity must be recognized immediately. You see, organophosphates bind acetylcholinesterase, forming an extremely stable covalent bond. To regenerate the cholinesterase enzyme, an agent called pralidoxime is often used. Think of putting a lid on this toxic insecticide, or pralidoxime. This agent can hydrolyze that covalent bond and regenerate the cholinesterase at both muscarinic and nicotinic receptors. It's just like this guy here who's bringing out a new line of toxic waste dumpsters. It's important to note, however, that pralidoxime is ineffective in reversing the central effects of organophosphate poisoning because it can't enter the CNS. So to reverse the central muscarinic effects, atropine, a muscarinic antagonist, is administered. See atropine Alice here on the side of the dumpster? An arrow points inside that psychedelic head of hers because atropine treats the peripheral effects and CNS effects of organophosphate inhibitors. But remember, atropine only reverses muscarinic effects, so it can't reverse the paralysis. Pralidoxime, which regenerates the anticholinesterase at muscarinic and nicotinic receptors, is going to be your agent that reverses that neuromuscular blockade. But remember, you better hurry because pralidoxime is not as helpful if the organophosphate and cholinesterase completely bind and undergo a process called aging. See this old man here who's been spraying pesticide in this inner city since before you were born? He represents the aged organophosphate cholinesterase complex, practically irreversible at this point, as you can tell by the gaping, corroded hole in this cholinesterase dumpster. Okay, to wrap up this intercity tour, I wanted to briefly mention the acetylcholinesterase inhibitors used in the treatment of cognitive dysfunction in patients with Alzheimer's. See this little park across the street? Well, a few of the local residents are throwing a little gala for Alzheimer's awareness. Let the word gala remind you of the drug galantamine. Under it, reverse the stigma represents rivastigmine. And see these two old folks here, still as sharp as a tack, completing the jigsaw puzzle? Because they are done with the puzzle, it represents the drug donepezil. The picture of the brain should remind you that donepezil, rivastigmine, and galantamine are acetylcholinesterase inhibitors that can penetrate the CNS to treat cognitive dysfunction in patients with Alzheimer's, though their benefit is generally modest. Because of all this extra acetylcholine, as depicted by these crisp, cool bottles of acetyl cola they're enjoying, these elderly patients can experience some serious side effects, so be careful. Alright, time to sum up this sketch. Indirect sympathomimetics work by inhibiting acetylcholinesterase, thereby increasing concentrations of acetylcholine at the synapse. Just like that tipped-over dumpster expelling acetyl cola bottles into the street. So they amplify the actions of endogenous acetylcholine, and these effects are important at both muscarinic and nicotinic receptors. Important nicotinic receptors to keep in mind are those at the NMJ that can be inhibited by autoantibodies in myasthenia gravis. Pyridostigmine and neostigmine can reverse myasthenia symptoms, just like the reversal of the gravis graffiti at the end plate here. The edrophonium phone can diagnose myasthenia with short-term relief of symptoms. But if the phone don't work, it's likely a cholinergic crisis instead. Neostigmine and similar agents can reverse the non-depolarizing neuromuscular blockade caused by the curare-like crayons. But during phase 1 of the depolarizing blockade caused by succinylcholine, this will only make it worse. Across the street, the phys ed center represents physostigmine, which can penetrate the CNS to treat all the effects of atropine overdose. Organophosphates are the most common cause of cholinergic toxicity, which manifests as the muscarinic dumbbells and the nicotinic paralysis. Pralidoxime can treat both. Atropinalis, however, can reverse the CNS symptoms. Galantamine, rivastigmine, and donepezil are cholinesterase inhibitors that can penetrate the CNS to provide moderate benefit to patients with Alzheimer's. We just finished indirect cholinomimetics. Congratulations.